Hi, my name is Camila Ramirez, and this is my health assessment final practical. First, I will begin with hand hygiene by washing my hands with soap and water for at least 30 seconds. I'll then put on PPE. For this is only gloves because I will be touching my patient. If they had any other precautions, I would put the appropriate PPE on. I'm going to close the curtain for patient privacy and then introduce myself. Hi, my name is Camila. I'm going to be your student nurse. What's your name?
Alana.
And where are you?
In the hospital.
And what year is it?
2020.
Okay. Based on this, I can tell that my patient is alert, awake, and oriented times 3. That's person, place, and time. I'm now going to ask her a couple of questions. Do you have any allergies?
No.
Do you have any past medical history that I should know about?
No.
Do you take any prescription meds?
No.
Do you take any home herbal supplements or over-the-counter?
No.
Do you smoke?
No.
Do you drink alcohol?
No.
Do you do any recreational drugs?
No.
Do you exercise?
No.
Do you perceive yourself as a healthy person?
Yes.
Okay. Now I'm going to ask my patient for permission to actually perform the assessment. I'm going to be performing a head-to-toe assessment in which I will be touching your body and looking at your body without a shirt on. Is that okay?
Yes.
Okay. Now I'm going to begin with the head and neck portion of the exam. I'm going to start with Perla, in which I will shine a light in my patient's eye and expect direct constriction of that eye, shine it in the same eye, and expect consensual constriction of the other eye, and I would do this on both eyes. I'm then going to have her look at my pen light, and I'm going to bring it close to her face. I expect constriction and conversion of the eyes. I'm then going to look at her sclera. I expect them to be white. I don't want to see any discharge or discoloration. I'm going to look at her conjunctiva, pulling her eyes down. I expect these to be pink and moist. I'm going to look at her mucous membranes, have her open her mouth, and I expect this to be pink and moist as well. I'm then going to assess her trachea, and I expect it to be midline. I'm then going to palpate her carotid pulses, one at a time, because I don't want to occlude blood to the brain. And I would palpate this for 60 seconds, expecting it to be 2+. I'm then going to test her cranial nerve number 11 by having her turn her head side to side against some resistance and shrug her shoulders against some resistance. I'm also going to now move on to the respiratory portion of the exam. I'm going to start with inspection. So for this, I would typically have no shirt on my patient to inspect the skin, but for the purpose of this test, she will have a shirt on. I'm going to inspect the skin. I expect her skin to be congruent with her ethnicity, equal. I'm then going to inspect the AP transverse diameter. Can you please stand up? So anterior, posterior to transverse. The ratio should be 1 to 2. If the ratio were 1 to 1 or 2 to 2, that would be barrel chest, which is indicative of a condition such as COPD. I'm going to be looking at her respiration without her knowing so that it's normal. I'm going to be looking at her respiration rate, in which I would expect it to be 12 to 20 beats per minute. And I would also be looking for chest rise. I expect it to be equal. And I will now begin with palpation. So I'm going to have her turn around, and I'm going to do the symmetrical chest expansion test. And I'm going to place both my hands at vertebrae T9, T10, which is around her elbows. I'm going to have her breathe in and out. And I expect my hands to move out and back and equally. Abnormal finding would be that one hand moves out more or less than the other. I'm now going to do tactile fremitus test, and I'm going to use the ulnar surfaces of my hand and place it on her lung fields. I'm going to have her repeatedly say the word 99.
99, 99, 99, 99.
Okay, so moving down, I'm feeling for all her lung fields, and I'm expecting to feel an equal vibration on both of my hands. If I were to feel a stronger vibration on one hand, that would be indicative of consolidation or fluid in the lungs. If it were to be a weaker vibration, that could be obstruction of the lungs. And yeah, okay, thank you. So now for percussion of the lungs, I'm going to be doing a posterior approach as well. I'm starting at the apices of the lungs, skipping the scapula and going back out for the peripheries of the lungs. I am going to listen for resonance. That's what I expect to hear in the lung fields. So now, you can have a seat, please. Thank you. And I would compare both sides to make sure that both sides of the lung fields are equal. So diaphragmatic excursion. What that is a test to test for where the diaphragm is and to see how much it moves with inspiration and expiration. So I would percuss the lung fields. I expect to hear resonance. Once I hear dullness, that is where the diaphragm is. I will mark that. And I would do that while I have my patient exhale and hold. Then I would have my patient inhale and hold, and again percuss until I hear dullness, mark that area. And the area between those two marked areas, the distance, should be about 3 to 5 centimeters. Now I'm going to auscultate. So I can do this in 3 different areas. So I can listen for the bronchial, vesicular, bronchiovesicular, and vesicular. So for the bronchial, I can listen in 3 different areas, 1, 2, 3, with the stethoscope. I'll listen on each side, comparing each side. I expect to hear expiration longer than inspiration. For bronchiovesicular, I'll have my patient stand up and turn around. I'm going to be listening on either side of the spine, again moving in a systematic approach, side to side, down, side to side. And here I expect the inspiration to be equal to the expiration. And then for the vesicular, I'm going to have my patient turn around just slightly. Under the armpit, around the scapula to the back, I'm listening for the periphery lung fields. And I expect inspiration to be longer than expiration. Okay, now I'm gonna do the bronchophony test. So again, in a systematic approach, side to side, I will be listening while my patient repeatedly says the word 99.
99, 99, 99, 99.
And I expect to hear a muffled 99. If I were to hear a very clear 99, that's indicative that there is consolidation in the lungs. And we do this test when we suspect consolidation of the lungs. Now for the cardiac portion of the test, I'm going to have my patient lie down. For inspection, I'm going to be looking for jugular vein distension. So I'm going to have my patient turn their head to the left so I can see the jugular vein on the right. I'm going to be using the 2 ruler test. So one of the rulers I'm going to line up at the highest point of distension of the jugular vein. The other ruler I will locate at the angle of Louis. I'm going to line both of the rulers up at 90 degrees, and I should measure less than 3 centimeters for a normal finding. Anything higher than that would be indicative of jugular vein distension, in which I would further test using the hepatojugular reflux test. I'm also going to palpate. So I'm going to perform a chest wall sweep, palpating the pericardium. I'm feeling for any heaves or lifts. Any thrills, heaves, or lifts are, a relocation of the point of maximal impulse. Thrill is a murmur of grade 4, 5, or 6. Now I'm going to auscultate in a systematic approach, auscultating in 4 different areas: aortic, pulmonic, tricuspid, and mitral. So to locate the aortic, I'm going to locate the suprasternal notch, move down to the angle of Louis. Immediately to the right is the aortic. That's at the second intercostal space on the right sternal border. And I will hear S1 and S2 low dub, with S2 being louder because we are at the base of the heart. I'm going to move over the sternum, second intercostal space, left sternal border, to listen to the pulmonic heart sound. I will hear S1, S2 being louder because we're still at the base of the heart. I'm going to move down 1 space. I'm now at the third intercostal space of the left sternal border. I'm going to hear for the tricuspid heart sound. I'm going to hear S1, S2. This time S1 will be louder because we're at the apex of the heart, or closer to the apex. And then I'm going to locate the midclavicular line, move down to the 4th intercostal space. And here I can hear the mitral heart sound, and this is the PMI, the point of maximal impulse. So using the bell of my stethoscope, I can hear low-pitched sounds. So I could hear sounds such as S3, which you would hear after S2, S4, which you would hear before S1, and murmurs, which is turbulent blood flow in the heart. And again, I said that a murmur S4, grade 4, 5, or 6 would be felt as a thrill, which is a vibration. I can also listen for the carotid using the bell, and I could listen for bruise, which is turbulent blood flow not in the heart. Now I'm going to inspect the abdomen I'm going to be inspecting the skin, making sure that the color is congruent with her ethnicity, that it's equal, that there aren't any lesions, anything abnormal. I'm going to be noting the size of the abdomen and the contour. Normal would be flat or round, abnormal would be protuberant or scaphoid. And then I'm going to auscultate. So we don't want to start with palpation or percussion because we don't want to create any unnecessary or unnatural peristalsis sounds. So I will auscultate starting in the right lower quadrant because that's where the ileocecal valve is and that's where peristalsis starts. A normal finding is 5 to 30 vowel sounds. Hyperactive would be above 30 sounds. Hypoactive would be below 5 sounds. And if I don't hear any vowel sounds for 5 minutes, then I could consider that absent vowel sounds. I will then percuss. When I percuss the abdomen, I expect to hear tympany unless I'm over a solid organ, which I would hear dullness. I'm starting at the right lower quadrant and moving in clockwise manner. And now I will palpate. But before I palpate, I'm going to ask if my patient has any tenderness or pain. Do you have any tenderness or pain?
No.
So then I can begin in the right lower quadrant. I'm going to palpate with my fingertips. For light palpation, I'm only pushing down 1 to 3 centimeters. I'm feeling for any masses, any lumps, bumps, any hardness, anything abnormal. And I'm noting to see if that elicited any pain or tenderness in my patient. If it didn't, then I can proceed to deep palpation, which would be 5 to 8 centimeters. And now for the upper extremities. Can you stand up, please? So I'm going to inspect the upper extremities. I'm going to be inspecting the color, that it's congruent with her ethnicity, the turgor, and noting for any alterations, anything abnormal. I'm going to now test her profile sign. So I'm going to have her point her fingers together, and I'm going to note the angle at her nail bed. It should be less than 160. Above 160 would be abnormal, and that's indicative of clubbing. Clubbing occurs when there is chronic hypoxia. Now I'm going to palpate. Using the back of my hand, I'm going to feel that her skin is warm and dry, that her skin is smooth. I'm going to be testing for a capillary refill, so I'll press on her nail bed, and when I let go, the blood should refill in less than 2 seconds. I'm also going to feel for her radial pulse and her brachial pulse. I could also feel for her axillary pulse. And I would do this for 60 seconds. I expect it to be 2+. And for the lower extremities, I would do the same. I would inspect the skin color, making sure that it's equal, congruent with ethnicity. I can feel that her skin is warm and smooth. I can feel for pulses as well. I could do the pedal pulse or the tibial pulse. The pedal would be on top of the foot. Tibial would be on the medial portion of the ankle. And I could also look for varicosities in the legs. I'm going to have my patient walk and back. And then I'm going to have her do the same, but now heel to toe. And I'm looking for any imbalances, any ataxia, which would be abnormal. A little bit of imbalance is okay. She's fine. Thank you. Now I'm going to be testing range of motion of the upper extremities and the lower extremities. So I'm just going to stand right here so you can see her. But I'm going to be performing with her. So I'm going to start with the cervical portion. So I'm going to do flexion, which is bending down, extension, hyperextension, and now for lateral bend to the right, lateral bend to the left, rotation to the right and to the left. For the thoracic portion, I will have her flex, extension, hyperextension, lateral bend to the right, lateral bend to the left, rotation to the right, rotation to the left. For the shoulders, I'm going to have her do forward flexion, extension, hyperextension, adduction. Abduction would be moving the arms out, away from the body, and adduction would be moving them across the midline. For the elbows, wrists, and fingers, we're going to do all at once. So I'm going to have my patient flex her arms, her shoulders. For the elbows, we're going to test flexion, which would be bending them back. That extension, out straight, pronation, which is what we're in right now, supination the other way. For the wrist, I'll have her flex her wrists, extension of the wrist, and hyperextension of the wrists, ulnar deviation, radial deviation. For the fingers, I'm going to have her flex, extend, abduct, and adduct. Okay, now for the hips, I'm going to have her flex the hip. And now I'm going to do the same with the knee bent. Extension would just be straight, and hyperextension would be yes, like that. We're going to do abduction, which would be moving the leg, right, ab, and then adduction, across the midline. External rotation would be moving the leg out this way, internal rotation this way. Now for the knees, by flexing, I'm going to have her bend her knees. Extension would be just regular standing. For the ankle, just so you can see. Plantar flexion would be pointing the toes. Dorsal flexion would be like that. Eversion with the thumb side down. Inversion with the pinky side down. Okay, and for the toes, I'm going to demonstrate on the hands. So we would have flexion of the toes, you're curling the toes, extension of the toes, regular, abduction of the toes where you fan them out, and adduction of the toes, you bring them back together. Now for genitourinary. I'm going to ask my patient if she has any difficulty urinating.
No.
Any pain while urinating?
No.
Okay. I'm also going to be doing some teaching. You could have a seat if you'd like. I'm going to be teaching about the flu vaccine. It's important that patients get the flu vaccine in order to prevent getting the flu influenza. It's especially important in patients that are immunosuppressed. They could easily go from an upper respiratory tract infection to a lower respiratory tract infection, which would be pneumonia. It's very easy to get your flu vaccine. You can get them for free most of the time with your insurance at any pharmacies. You can go to your primary to get that, and it's important that you get it for every flu season, which begins around the fall time. And so that's the end of my assessment. Now I'm going to conclude by washing my hands, and thank you for watching.